Welcome to the deep dive. Our focus today is dense, it's critical, and it's definitely high yield. The foundational principles of bone and cartilage grafting. If you're preparing for your exams, these concepts, from embryology to biomechanics, they can really be the difference.
They're absolutely essential.
So we are going straight into the biology, the clinical factors, everything you absolutely have to have mastered.
And we're charting a clear course. We'll start by establishing the structure and the embryological origins of bone because that really dictates its behavior.
Okay.
Then we'll transition into a deep comparison of primary versus secondary bone healing. From there, we'll spend a good bit of time on the 4 mechanisms of graft incorporation, the 4 O's, before we finish up with the unique challenge of warping in cartilage grafts.
Sounds good. Let's make sure that foundation is solid. Okay, let's unpack this right at the start with embryology. All bone derives from mesenchyme, but we have 2 functionally distinct paths to formation.
2 very different paths.
What are those 2 mechanisms? And I think importantly, what are the classic examples that define each one?
So the first path is intramembranous ossification. This is the direct deposition of bone within a highly vascularized sheet, a membranous template.
No cartilage involved?
No cartilage intermediary at all. You should think of the flat bones, the calvarium, most of the flat bones of the face, like the maxilla and zygoma and the ribs.
Which means for our purposes, when we're doing craniofacial work, a lot of the bone we're dealing with, we're borrowing, is formed this way.
Precisely. And the second mechanism is endochondral ossification. This is bone development that starts with a cartilage precursor, or what we call an annulage.
Right.
The cartilage template gets laid down first, then it's mineralized and replaced by bone. This is the pathway for, nearly all our load-bearing structures.
With all the long bones?
All the long bones, and critically, the iliac crest, our workhorse donor site.
Okay, so we've got bone that grew directly from a membrane and bone that grew from a cartilage model. Now, here's the clinical takeaway. Does that innate difference, how it grew, affect its handling or behavior when we use it as a graft?
Oh, absolutely. The structural outcome is just different. Intramembranous bone, so calvarial bone, is often cited as being more resilient to resorption.
When used as an onlay graft?
Yes. Specifically as an onlay graft in the face compared to endochondral bone grafts from, say, the iliac crest. This resilience really makes those membranous sources superior when maximum volume retention is the goal.
But it's a high-yield distinction right there.
Yeah.
Now let's talk pure structure. When we look at mature cortical bone, it's incredibly dense, very highly organized.
Yeah.
Can you describe that organization, especially its complex vascular pathways?
Of course. Cortical bone is structured into these multiple, tightly packed cylindrical units. We call them osteons.
Osteon.
And each osteon is built around a central haversian canal. This runs longitudinally, and it contains the central blood vessel.
And if we think of these as columns running up and down, how do the nutrient vessels communicate horizontally between them?
That's the job of the Volkmann canals. These are the transverse nutrient canals that interconnect adjacent osteons and link up all the haversian systems.
Got it.
And the bone itself is laid down in these concentric rings, or lamellae, around the haversian canal with the osteocytes, the mature bone cells. They're scattered within these little spaces called ichune. It's a highly efficient living scaffold.
Okay, now that we understand the structure, let's talk about native repair. A fracture can heal in 2 fundamentally different ways. First, secondary bone healing. This is the pathway we associate with non-rigid fixation, with motion. It parallels standard soft tissue healing.
It does.
Can you lay out the 5 phases in sequence for us?
So secondary healing, it needs motion, and it absolutely needs that fracture hematoma. The 5 phases are: first, immediate hematoma formation. Second is inflammation, where the hematoma starts to organize, and osteoclasts are recruited to remove all the necrotic bone debris.
So the cleanup crew arrives pretty early. What's next?
Third is cellular proliferation. This is the big recruitment of mesenchymal stem cells and a proliferation of cells from both the periosteum and the endosteum.
Okay.
And this is followed by the 4th phase, callus formation. Now, this is a 2-part process. You get a soft callus of osteoid and hyaline cartilage, which then mineralizes to form a bridge of hard-woven bone.
And that hard-woven bone, that kind of provisional structure, that isn't the final product.
Not at all, correct. The final phase is remodeling. And over months or even years, the immature woven bone of that hard callus is slowly replaced by a mature, stronger lamellar bone, restoring the original cortical structure.
Right, so that pathway relies on motion and a big cellular response, creating that callus we can see on an X-ray. Now, let's contrast that with primary bone healing. This is the pathway we force with compression and absolute rigid fixation. What are the specific requirements here, and how does it manage to bypass those inflammatory phases?
Primary healing is defined by the absence of callus formation. It needs direct bone end apposition and absolute stability.
The kind you get with plates and screws.
Exactly, with rigid fixation. Because the mechanical environment is so static, the bone doesn't need to bridge a gap with an external callus.
So it's not fighting movement. It can just proceed directly to restoration.
Yeah.
What's the fundamental mechanism then?
It becomes a direct process of osteonal bone remodeling. Instead of a massive inflammatory cascade, you get osteoclasts, acting like miniature tunneling machines that drill straight across the fracture site from one cortex to the other.
So the drilling creates a tunnel, which is immediately put to use.
Exactly. The osteoclasts are followed very closely by blood vessels and osteoblasts, establishing new haversion systems directly across that fracture gap. It restores the bone architecture without any of that temporary callus stage.
You know, it's a neater repair, but it's not necessarily faster.
That is a crucial insight. It's not. It's neater, and it provides early mechanical stability, but the speed of true cortical restoration might actually lag behind a well-executed secondary healing process in those initial weeks.
Okay, now that we've charted how native bone fixes itself, let's move to the much harder task. Making a dead piece of bone, a non-vascularized autograft, successfully integrate. This brings us to the 4 O's.
The 4 key mechanisms, yes.
Let's define the 2 more passive or scaffolding mechanisms first: incorporation and osteoconduction.
Incorporation is the most basic. It's simply the adherence and survival of the graft right next to the host bone. This is maximized when your recipient site is well vascularized and the graft is perfectly immobilized.
And osteoconduction is where that scaffold really starts to shine.
It is. Osteoconduction is the process where the graft acts as a physical matrix, like a highway. Vessels and osteoprogenitor cells travel along this scaffold from the host bone into the graft.
And this involves the slow resorption of the old graft bone while new host bone is being laid down.
That's the famous process known as creeping substitution.
Creeping substitution. It's effective, but it's inherently slow because it relies on that invasion and simultaneous replacement.
Very slow.
Which brings us to the active cellular mechanisms, which are often confused. Let's define osteoinduction first.
Right. Osteoinduction is the powerhouse mechanism for most non-vascularized grafts. It's the active biological signaling that causes the differentiation of local, undifferentiated mesenchymal cells.
So cells within the recipient bed.
Exactly. Into functional osteocytes, osteoblasts, and chondrocytes.
And what's driving this differentiation? What's the signal?
The whole process is controlled by powerful growth factors, but primarily the bone morphogenetic proteins, the BMPs.
That's a critical point.
Yeah.
BMPs are the key biological signal that turns surrounding tissue into bone tissue.
It is. And it's important to remember that for a non-vascularized graft, the original osteoblasts within that graft are dead or dying. They don't survive. They can't multiply.
So the new cellular growth has to come from the recipient site, driven by osteoinduction.
That's absolutely right. The cells in the original graft cannot undergo mitosis. It's all about recruiting local cells.
Which finally brings us to the 4th UA, osteogenesis. If osteoinduction is about recruiting host cells, what makes osteogenesis so unique?
Osteogenesis is the formation of new bone by surviving cells within the graft itself. This only happens in any significant way in a vascularized bone graft, a bone flap, where we've meticulously maintained the blood supply.
So because the cells are alive.
Because the cells are alive, the graft incorporates much more rapidly. It's laying down its own new bone immediately and doesn't have to rely so much on that slow, creeping substitution process.
Understanding why grafts fail is just as crucial for the exam as understanding how they succeed. Let's switch to factors influencing survival, starting with intrinsic graft factors.
Good idea.
Can you give us 3 specific properties of the graft material itself that really dictate its survival and resorption profile?
Okay, first, the inclusion of the periosteum. It's a major factor. Grafts with periosteum undergo significantly less resorption than those that are stripped of it.
Likely because of that maintained supply of osteoprogenitor cells.
That's the thinking. Second, the embryological origin matters again. Membranous bone is more resilient to resorption than endochondral bone when it's used as an onlay graft.
Which guides our choices in facial reconstruction.
It does. And third, structurally, cancellous grafts are just far more easily and rapidly revascularized than dense cortical grafts, so they're superior when you need volume fill and quick integration, not immediate mechanical strength.
And that leads directly into graft placement factors. Let's define orthotopic versus heterotopic placement and explain why the placement site matters so much.
Orthotopic placement is putting the graft into a site normally occupied by bone, like repairing a jaw defect. Heterotopic placement is putting it elsewhere, say using a rib graft to reconstruct the nasal tip.
And orthotopic grafts are just inherently less prone to resorption.
They are, because the biological environment there expects bone.
But beyond just bone or not bone, the quality of that orthotopic site also matters, right?
Absolutely. Grafts survive better in what we call depository sites. These are areas where the body is biologically used to laying down or maintaining bone. Think of the zygoma or the mandible, especially during growth periods in children. These sites are just biologically hotter.
A better healing environment.
A much better healing environment.
We've covered bone extensively. Let's switch gears to cartilage. What is the single most fundamental difference in cartilage's structure that explains why its healing is, well, typically fibrous, very slow, and extremely limited?
The defining characteristic is that cartilage is avascular, aneral, and alymphatic. There's no intrinsic blood supply at all.
None.
Which means its nutrition, its survival, it's all entirely dependent on the slow process of diffusion of nutrients through its matrix, which is mostly water, type 2 collagen, and GAGs.
So its structural simplicity is its biological Achilles heel. Because of that reliance on diffusion, the chondrocytes have almost zero intrinsic reparative ability once they're damaged.
Exactly. That slow diffusion does limit the immune response and allows it to resist ischemia longer than bone, which is why we can use costal cartilage as a free graft so successfully. But its major drawback remains warping.
Warping. The tendency to deform, which is the major clinical headache, especially when you're trying to create a smooth contour, like the nasal dorsum.
Where even minor curvature is noticeable through thin skin.
Right. So describe Gibson's principle. What causes this warping, and how do we use that knowledge?
So Gibson's principle explains the mechanics of warping as a kind of differential stress relief. It describes how the outer layer of cartilage acts like a taut skin. When you score or carve away the inner layer on one side, you release the intrinsic tension on that side.
Okay.
The opposing intact side retains its high tension, which causes the cartilage to predictably curve toward the side where you did the carving.
So it's not about the perichondrium anymore, but the inherent mechanical stresses within the matrix itself.
Correct. While early theories focused on the perichondrium, later experiments confirmed that removing it didn't stop the warping. It's entirely about these differential internal stresses you create when the cartilage is thinned unevenly.
And we can harness this.
We do.
Yeah.
Clinically, we harness this intentional warping in procedures like prominent ear correction, using the anterior scoring method to force a specific curvature.
Given that this warping happens because of intrinsic stress, and we know stress relief takes time, what is the critical advocated technique is based on the timing of that warping?
This is a vital practical detail. The vast majority of warping happens within the first 60 minutes after harvest.
The first hour.
Right, though slight shifts do continue for weeks. To maximize predictability, the technique advocates delaying implantation for at least 30 minutes after you harvest it.
Why?
It allows the graft to assume its initial major curvature before you fix it rigidly into its final position. You're fixing the curve, not the straight piece.
That brings us to the end of our deep dive. We've locked down the embryological difference between membranous and endochondral bone, clearly distinguished the mechanisms of primary versus secondary bone healing,
and define the critical roles of the 4Os, especially that difference between BMP-driven osteoinduction and cell-surviving osteogenesis.
Exactly.
And remember those high-yield intrinsic factors. Cancellous bone revascularizes faster than cortical bone, and membranous bone is structurally more resistant to resorption than endochondral bone when placed as an onlay graft in the face.
Those are the specifics that lead to the right choices?
And the high board scores.
So as a final thought to chew on as you're cementing this knowledge, if cartilage allografts are inherently limited because the eventual breakdown of the matrix exposes those foreign chondrocytes to rejection, but bone matrix is mineralized, generally more inert, does this maybe suggest that bone allografts, the non-viable ones, rely almost entirely on that passive mechanism?
On pure osteoconduction.
On pure osteoconduction, right? That inert scaffolding function for their long-term integration, rather than any active osteoinduction from whatever residual proteins are left. Just something to consider as you study the material.